Okay, so you want to stop aging. You've reached a point where recovery takes just a little bit longer than it used to. The morning stiffness stays around through your second cup of coffee. You notice that despite eating the same diet and doing the same workouts you did a decade ago, soft tissue accumulates around your midsection while muscle mass quietly slowly erodes. And then you hear about human growth hormone. Growth hormone is highest when you're young. Young people heal faster, build muscle more easily, recover from injuries quicker, and generally have firmer skin and lower body fat. As you age, natural growth hormone levels steadily decline. So the market presents a simple, elegant math problem. If losing this molecule made you age, injecting it back into your system should make you young again. Anti-aging clinics show you before and after photos of 60-year-olds with 16-inch biceps and washboard abs. Prominent executives and fitness influencers speak in hushed, reverent tones about synthetic peptide injections that erase wrinkles, incinerate visceral fat, and restore the vitality of a 25-year-old. It feels less like a drug and more like restoring a missing compound that time unfairly stole from you. That is what you're told will happen. Here is what your body is actually doing while you wait for the time to feel young again. Before we look at what goes wrong, we need to understand how this system is supposed to work when your body is left to its own devices. Deep inside the center of your head is a pea-sized organ called the pituitary gland. Every night, roughly an hour or two after you fall into deep, your hypothalamus sends a chemical signal called growth hormone, releasing hormone to the pituitary. In response, the pituitary releases human growth hormone, called as somatotropin, directly into your bloodstream in sudden, sharp pulses. Somatotropin does not act alone. Once released, it travels through your circulation to your liver. There, it attaches to cellular receptors and sets off a chain reaction, generating a secondary master signal known as insulin-like growth factor 1 or IGF-1. Think of growth hormone as the initial signal horn and IGF-1 as the construction crew that actually carries out the orders throughout your body. Together, this biochemical axis governs two fundamental biological engines: anabolism, which is tissue building, and lipolysis, which is fat breakdown. When growth hormone binds to a fat cell, it signals that cell to break down stored triglycerides into free fatty acids to be burned for energy. When IGF-1 binds to muscle, cartilage, or bone tissue, it opens up cellular pathways that pull amino acids out of the blood and stitch them into new proteins. It stimulates chondrocyte, which are the cells that build joint cartilage, and osteoblasts, which build bone matrix. It also suppresses programmed cell death, a process known as apoptosis, essentially telling cells to stay alive, adapt, and grow. During childhood and adolescence, this system operates at full capacity. It drives linear bone growth, expands organ size, and builds structural muscle mass. But once your bones fuse and you reach full physical maturity, your body deliberately turns this system down. By age 30, your pituitary gland reduces its nighttime secretory spikes. By age 60, most adults secrete less than half the growth hormone they did in their early 20s. Endocrinology calls this age-related decline the somatopause. For decades, medicine viewed the somatopause as a defect, a slow decay of a vital endocrine organ. But modern systemic physiology views it very differently, a deliberate evolutionary trade-off designed to protect a mature body from overgrowth and metabolic collapse. When an older adult begins injecting synthetic growth hormone, recombinant human growth hormone, or RHGH, the short-term physical transformation can appear almost miraculous at first glance. The landmark moment for this trend occurred in July 1990, when Dr. Daniel Rudman published a famous clinical paper in the New England Journal of Medicine. Dr. Rudman took 12 men aged 61 to 80 who had low baseline levels of IGF-1 and administered recombinant growth hormone 3 times a week for 6 months. The immediate, first-order metrics were startling. The men experienced an average 8.8% increase in lean body mass. Their body fat dropped by 14.4%. Skin thickness, which naturally declines with age as collagen degrades, increased by over 7%. Bone density in the lumbar spine rose by 1.6%. Their blood markers showed serum IGF-1 levels rising from low elderly baselines back into the range typical of men 30 years younger. Without changing their diet or exercise regimens, these men had physically shifted their body composition backward by roughly 2 decades. These are the exact numbers that anti-aging clinics still quote today on their websites and in marketing materials. On paper, the mechanism works precisely as promised. Stored fat melts off because lipolysis is forcibly upregulated. Skin plumps up because dermal fibroblast collagen synthesis is reactivated, and lean tissue swells as cells retain nitrogen and pull in water. If you stop reading the literature in 1990, human growth hormone looks like the long-sought holy grail of longevity science. But Dr. Rudman's trial was only 6 months long, and it measured basic surface parameters. When medical science began looking deeper at what was happening beneath those superficial gains, the picture changed dramatically. To understand the hidden cost of growth hormone, you have to look at a biological reality that anti-aging marketing ignores. Human growth hormone is a metabolic antagonist to insulin. Under healthy conditions, when you eat food, your pancreas secretes insulin to push glucose out of your blood and into your cells for energy or storage. Insulin is the primary signal for cellular uptake and energy storage. Growth hormone does the exact opposite. Because its primary job in nature is to mobilize energy reserves during periods of fasting or stress, growth hormone actively blocks insulin from doing its job in fat and muscle tissue. It induces what endocrinologists call acute insulin resistance. When you inject synthetic growth hormone continuously, this transient safety feature turns into a chronic metabolic condition. Your liver begins releasing steady streams of glucose into the blood, while your peripheral cells refuse to absorb it. In response, your pancreas panics and pumps out higher and higher amounts of insulin to force that glucose out of circulation. You enter a state of chronic hyperinsulinemia combined with elevated blood sugar. Over months and years, this state destroys pancreatic beta cell function and can trigger full-blown type 2 diabetes, even in individuals who look outwardly lean and muscular. The second major hidden cost lies in fluid dynamics and pressure mechanics. Growth hormone causes the kidneys to aggressively reabsorb sodium and water. This fluid does not just sit harmlessly under the skin. It expands the total volume of your blood and fills the extracellular matrix surrounding your nerves and joints. As soft tissue expands inside fixed anatomical spaces, it creates physical compression. The median nerve running through your wrist gets crushed beneath swollen connective tissue, creating severe carpal tunnel syndrome. Joints fill with fluid, leading to persistent, deep aching stiffness known as arthralgia. And then there is the most dangerous second-order effect of all, unconstrained cellular proliferation. IGF-1 is one of the most potent mitogens in the human body. It instructs cells to divide, duplicate, and refuse to die. In a 20-year-old body, tissue genetics are relatively clean. In a 60-year-old body, microscopic, silent precancerous mutations already exist across various tissues. Colon polyps, tiny thyroid nodules, dormant prostate lesions, and microtumors are held in check by a declining hormonal environment and an active immune system. When you flood an aging body with high levels of exogenous growth hormone and IGF-1, you are not just signaling your biceps and skin to repair. You are pouring high-octane fuel onto every silent, mutated cell in your body. IGF-1 blocks the natural apoptotic mechanisms that would normally force a mutated cell to self-destruct. It promotes angiogenesis, the growth of new blood vessels, supplying nutrients directly to emerging tumors. The systemic paradox of anti-aging growth hormone therapy becomes clear. The exact same pathway that temporarily makes a tissue look younger accelerates the underlying cellular machinery of metabolic decay and oncogenesis. The reason people fall into the growth hormone trap is that the human feedback loop is deeply misleading. When someone starts anti-aging doses of growth hormone, the initial feedback is entirely positive. Within 3 to 6 weeks, subcutaneous fat thins out. Water retention in muscle bellies gives the body a fuller, tighter appearance. Sleep depth often improves initially because of central nervous system effects, and minor skin wrinkles smooth out from increased dermal extracellular water. Because these visible markers align perfectly with the promise, the user assumes the drug is working flawlessly. They do not feel their fasting blood sugar creeping up from 85 to 115 milligrams per deciliter. They do not feel their insulin levels doubling to compensate. They do not see microscopic colonic adenomas, increasing their cellular division rate threefold. The line between beneficial physiology and pathological damage is determined by dose and biological context. In healthy aging, the somatopause is not a system failure. It is a protective adaptive mechanism. Nature intentionally lowers growth hormone levels as you age because an older genome accumulates DNA damage. High growth factors in an old organism equal rapid tumor progression and vascular degeneration. In fact, evolutionary biology and animal models show a striking, consistent truth. Mice with genetic growth hormone deficiency or growth hormone receptor resistance do not die young. They live up to 40 to 50% longer than normal mice and are remarkably resistant to cancer and age-related diabetes. Similarly, humans with Laron syndrome, a rare genetic condition characterized by a severe lack of IGF, one due to growth hormone receptor deficiency, almost never develop cancer or type 2 diabetes. The anti-aging narrative flips this biology on its head. It treats a protective evolutionary break as a disease state that needs to be overridden with heavy pharmacological intervention. The trap springs when subtle side effects begin to appear. A user notices their hands tingling in the middle of the night or their wedding ring feeling tight. Their joints start aching after basic workouts. Instead of recognizing these as clear warning signs of excessive tissue hydration and systemic nerve compression, anti-aging protocols frequently advise patients to push through, adjust peptide combinations, or add secondary drugs like metformin to handle the rising blood sugar. By the time the individual realizes something is wrong, their metabolic flexibility has been compromised, their baseline pancreatic insulin sensitivity has eroded, and any underlying cell mutations have been given months or years of powerful growth stimulation. To see how this cause and effect chain plays out in real life, we can look at the long-term clinical trials that followed Dr. Rudman's initial 1990 enthusiasm. Following the publication of that first paper, researchers across the world sought to replicate and expand the findings to see if growth hormone could truly be prescribed as a mainstream anti-aging intervention. One of the most comprehensive follow-up efforts was a series of rigorous, placebo-controlled trials conducted by researchers affiliated with the Department of Veterans Affairs and published in major journals throughout the late 1990s and 2000s, including systematic meta-analyses compiled by Stanford University researchers in 2007. Consider the documented profile of clinical study participants. Endocrinologically normal, healthy older men and women who entered these studies expecting rejuvenation. Take the case of study participants placed on standardized growth hormone replacement protocols designed to restore their IGF-1 to youthful levels. In one representative cohort of elderly subjects evaluated over several months, the participants did not experience an increase in functional physical performance despite gaining lean mass. Their muscle volume increased on scans, but their actual muscle strength, aerobic capacity, and functional mobility did not improve in any meaningful way. Why? Because much of the measured gain in lean mass was not functional contractile muscle fiber. It was intracellular water retention and swollen connective tissue. Meanwhile, the clinical cost mounted rapidly. Across these controlled trials, up to 47% of participants developed severe peripheral edema, painful fluid swelling in their hands, legs, and ankles. Up to 33% developed carpal tunnel syndrome, requiring medical cessation of the hormone. A significant fraction developed impaired fasting glucose or frank diabetes within months of starting therapy. The side effect rates were so high, and the actual functional benefits were so absent, that institutional review boards and clinical researchers were forced to halt multiple extension trials. The 2007 Stanford meta-analysis synthesized data from 22 secondary studies involving over 220 subjects. The conclusion was definitive. While growth hormone changed body composition numbers by modestly reducing fat mass and increasing fluid-based lean mass, it caused extraordinarily high rates of adverse events without offering any improvements in strength, performance, or overall longevity. The clinical reality was undeniable. Treating healthy age-related hormone decline with aggressive growth hormone replacement did not stop aging. It created an artificial state of mild acromegaly, a disease of pathological hormone excess. To evaluate growth hormone objectively, we must clearly separate legitimate medical therapy from anti-aging marketing. Growth hormone is an essential, life-saving medication when used within strict, evidence-based medical boundaries. But there is a vast, dangerous difference between treating true endocrine pathology and attempting to pharmacologically override normal human aging. When growth hormone therapy is done right, it is prescribed exclusively for true adult growth hormone deficiency. This is a rare condition caused by physical damage to the pituitary gland, usually from a tumor, brain surgery, radiation, or severe traumatic brain injury. Physicians confirm this diagnosis through formal stimulation testing, proving the brain is physically incapable of producing the hormone on its own. In these legitimate medical cases, doctors start with precise microdoses, typically around 0.1 to 0.3 milligrams per day. The therapeutic goal is conservative and precise, to gently bring serum IGF-1 levels back into the middle of the normal range for that person's specific age group. Patients are monitored closely with quarterly blood work tracking fasting blood sugar, long-term glucose markers, lipid panels, and IGF-1 levels. When managed this way, the treatment restores bone density, normalizes cholesterol, and reverses pathological fat accumulation without flooding the body with excess fluid or inducing metabolic damage. When growth hormone therapy is done wrong, it looks completely different. It starts when an endocrinologically healthy middle-aged adult attempts to treat normal age-related hormone decline. Anti-aging clinics often use static, unstimulated morning blood tests, which are medically meaningless due to the way growth hormone pulses, to tell clients that any IGF-1 level below that of a 20-year-old is a deficiency that needs fixing. In these anti-aging protocols, individuals frequently inject high daily doses ranging from 2 to 5 international units or more, sometimes stacked with synthetic growth hormone-releasing peptides. The explicit goal is to forcibly drive serum IGF-1 levels back to where they were in early adulthood, or even higher. Instead of restoring health, this aggressive approach pushes an aging body into chronic insulin resistance, elevating the long-term risk of type 2 diabetes. It fills extracellular spaces with excess fluid, leading to painful joint swelling and carpal tunnel syndrome, while creating a high-growth environment that suppresses cellular suicide and fuels the growth of dormant, mutated cells. Aging is not a deficiency disease waiting for a chemical patch. It is a carefully balanced survival strategy written into your DNA. When you try to force an old engine to run at young RPMs, the clock isn't what rewinds, the machinery breaks.